So it's my pleasure now to invite Dr. Bala Murugan to speak to us on evaluation of a patient with uveitis. Dr. Bala Murugan is the head of uvea service at Arvind Pondicherry.
A pleasant good morning to one and all. After such a wonderful talk on OCTA, my talk on evaluation of patients with uveitis will be very, very basic or rather ultra basic. So uveitis, I call it as mother of surprises. It's surprise not only for you, not only for we, it's for everyone. It's a mother of all surprises. So the basics in handling uveitis starts with first talking to the patients. See, post-COVID, we have all become very negligent in talking more to the patient, describing all the complaints, evaluating all the systemic associations that needs to be really, really looked into. So this was a wonderful article where I was fortunate to be the co-author, where it has been really captured that 75% of the diagnosis can be properly achieved if you do meticulous history taking. Underline, it is meticulous. So it is a cornerstone in the management of uveitis. If you bypass this history taking and outsource to some other person, however you do meticulous investigation, treatment, you will end up in problem. So history is the cornerstone. So the rules in uveitis practice, my teacher has taught me that meticulous history taking is prerequisite, not only for diagnosis and also for correct treatment. The second rule is, again, don't forget rule number 1. So it may look something you have heard somewhere else. So please remember, history is very, very important. So look at this case. This was a 42-year-old lady who presented with keratouveitis. If you can see some granulomatous keratic precipitates as well as. And the patient was started on topical steroids. So the patient came back after 2 days for the reading of the Mantoux test, and look how it flared up. So what was the history that was overlooked? That history of native treatment. So it's a violent case of Aspergillus fumigatus, which we were able to identify and publish as well. The second point in the evaluation of uveitis is evaluate and examine each and every part of the eye. So before correlating the symptoms, so we need to be very, very careful that we examine the eye properly. A lot of people forget that there are 2 eyes and the eye is part of a body system. So you can't say that I did not do IO, I missed the peripheral error, and nobody will excuse us. So if the fundus is not viewable, B-scan is always there. So my impressive teacher has taught me that if you do only 90-day examination, you are going to miss a lot of the parts of inside of the eye, which you should not be doing it. The single most take-home message is, whenever you see uveitis, don't forget to do IO. Because I see a lot of students just seeing only the slit lamp, not only bothering to make the patient lie down and do IO. And now I see the next generation postgraduates doing IO in the sitting posture. I don't know how they will be able to see the pars plana. It is really, really impossible unless you are a super duper IO person. So make sure that you meticulously do an indirect ophthalmoscopy. Don't miss certain peripheral findings. And the third important point is reach an anatomical clinical diagnosis. This is not something fancy. See, it's not a big deal. You can easily reach anterior, intermediate, posterior, or pan-uveitis based on what all elementary stuff you all know of it. So based on that, outline a list of differential diagnosis and then proceed with the definitive plan. So the descriptors Sun has given, onset, duration, course. This was Sun 1. And if you happen to see, the Sun 2 has also come. Each of the 25 uveitic entities, they have defined what to use as descriptors of uveitis. So the most important is chronic and acute. Chronic is more than 3 months and acute is of a lesser duration. What is important is, in uveitis there is no terminology called subacute. So please remember, it is either acute or chronic. or in between there is recurrent. Okay, and this descriptors of uveitis as granulomatous and non-granulomatous is very, very elementary, which is easily overlooked. See, you don't say cataract as cataract. You describe as immature, mature, hypermature. Similarly, always whenever you see a KPs, keratic precipitates, qualify them as granulomatous or non-granulomatous. You can be wrong. There could be borderline, which we call as microgranulomatous. So you all know that the list of differentials is going to change as we see in the subsequent slides. And this is one important thing which you should always keep in mind is we should be malleable. We should be shameless to change the diagnosis. And I say that I need to revisit the diagnosis each and every step. Uveitis is dynamic. The dynamicity of the clinician should match the dynamicity of the disease process. If you are not dynamic and not changing as per the change that is happening, we may end up wrong. Look at this illustration. Sometimes things are not the same as they look like. This was a patient who was present with defective vision of 1/60, and you see some funny looking macular choroidal lesions, and we did an FFA. If you carefully see, there was some peripheral vascular leak, and we did all the investigation. Mantle showed necrotic mantle, which was sort of pustule and all those big ulceration with raised ESR. So this necrotic mantle is seeing like a histopathological slide. No wonder we started on ATT along with oral steroids. What happened was the inflammation recurred when the steroids were down tapered, and even the other eye got involved. And you can see a lot of hemorrhages around the vessels as well. The vision, which was 6/6 in the other eye, dropped to 3/60. And we again repeated FFA. As you see, there is an N large FAZ, and you could see a lot of peripheral vascular lesion as well. And now, looking at this early phase carefully, you can easily see the scattered tract appearance, mid phase as well, and the late phase. So what do you see? There is an ocular ischemic syndrome. So I checked the blood pressure in the limbs. There was an absent radial pulse. And the BP upper limb, lower limb, there was a difference of 210/120. So even a basic examination of blood pressure checking can help you in reaching this wonderful diagnosis of severe Takayasu arteritis. So you see such severe uveitis, you are supposed to handle with a rheumatologist along with high dose immunosuppressant, preferably a cyclophosphamide or an IV methylpred. That could have easily salvaged the patient. So don't be carried away only by the investigations. Just because we started ATT, don't be very arrogant in not revising the diagnosis. So when there is a lack of steroid response, there are multiple possibilities. What are they? The first one could be a possible infectious uveitis, straightforward. It could be an aggressive non-infectious etiology, again looks plausible. Fungal uveitis could be like one other possibility. It could be a metabolic masquerades, or even a straight masquerade like lymphomas, leukemias, or even an ocular ischemic syndrome, which could masquerade as uveitic entitis. So keep all your options open. So lack of steroid response could be multidimensional. And the next important message is be a clinician. So I'm very fancied of uveitis because I need to be very, very clinical and take each of the investigations as a pinch of the salt. All the reports, including the histopathology, needs clinical correlation and need to be taken as a pinch of the salt. So before ordering the test, have a plan what to do. So without a plan, if you order all the tests, it will be a maze. So there is something called pre-test probability of the test. That depends on the population you are working in. So if you don't know what you are looking for, you may not find an answer or you may find a wrong one. So sometimes investigation is not at all required. When you are sure of the etiology, say a traumatic uveitis or a Fuchs uveitis, some people say low grade non-granulomatous. However, some investigations are meticulously mentioned not to be ordered. What are they? ELISA TB test. I see still people ordering. There is WHO has banned this test. Quantiferon TB Gold as a replacement for traditional MANTO. It's not a replacement, it's just a supplementary. Toxocara antibodies, it's not validated. You need to be a good clinician. And chest X-ray, if you order APU instead of PAVU, it could be a maze. You will not see the details. Serum titers for HSV, VZV, CME by ELISA, again, the pre-test probability is very poor that you need not order all these useless investigations. And sometimes common sense is very, very important. Don't have to read a lot of articles to order investigations. If you see a patient with a worm in the anterior chamber, what test are you going to order? Nothing. You just take the patient to the OR, remove the worm, and examine the worm under the microscope. The job is done. Don't do all fancy stuff at this position. Like, what else you have to do? Order for a poor personal hygiene and do a health education and an anti-helminthics to prevent the systemic infection as well. So, when we do proper history taking, you can even get ideas to do PhD as well. So, when I was a postgraduate, I used to work with my mentor, who used to get a lot of patients called anterior chamber granuloma as well as conjunctival granuloma. So we used to do all the Mantoux tests, all the investigation. Those days, these patients were given an ATT also. Sometimes we, in a camp, we saw a lot of clustering of these patients, and we asked that what history is relevant there. And the history relevant was taking bath in ponds. And this happened to be a river water granuloma, and we were able to identify a new worm that is causing ocular manifestation called Procerovarum varium, and this is a new entity called trematode-induced uveitis, which presented as granulomas. So materials history taking even helps you to reach PhD degree as well if you do a PCR from the granuloma and identify the organism. So, sometimes on examination, we need to be very, very vigilant. You see an eye which is peripherally shallow, centrally deep, looking little funny. So, we have to ask, why the central is also not deep? So, what you are going to do at this juncture is order a UBM, look for cyclitic membrane. Why cyclitic membrane? The approach to handle this uveitic cataract is going to be entirely different. If cyclitic membrane is associated, you are going to remove this cataract surgery using a posterior approach, pars plana approach, rather than an anterior approach. So UBM is very, very important, and you may even do a staged cataract surgery. So this configuration of cataract precipitates are so important to reach the different etiology. For example, sarcoid TB toxo, there will be a large granulomatous, and this gravitational distribution will be there in the herpes simplex zoster, whereas Fuchs will be non-gravitational diffuse stellate. And the most important, the post-nurse Glassman syndrome, there will be medium size or inferior peripheral iodocorneal angles. So the configuration of keratic precipitates are also important. So sometimes keep an eye open, rule out the pseudo-Fuchs, never to miss the sarcoid as well as the syphilis, which are easily the masquerades of Fuchs uveitis. So, as you see in this patient, there is diffuse granulomatous stellate keratic precipitates. Even gonioscopy showed this wonderful finding of 10-shaped peripheral anterior synecdoche, which is a diagnostic criteria for ocular sarcoidosis. So, why the specific diagnosis? We have to break our head because the treatment is going to be entirely different. Fuchs uveitis, no topical steroids, no oral steroids. This is the single most take-home message. I keep telling again and again, forgive me. And no cycloplegics preoperatively in Fuchs uveitis. You all agree there is no synecdoche and no cycloplegics. As I said, when there is vitritis, don't keep bombarding with steroids. So even general examination is very important. As you can see, when a patient walks in with all the deformities, with fibrinous uveitis, you will suspect HLA-B27. Iris nodules, COPY, it can be in both granulomatous, non-granulomatous. Busaka and angle KPs are very important, looking for TB and sarcoidosis, which is called Berlin sign. And of course, not to miss this neurofibromatosis causing Lisch nodules. Brushfield flex and Down syndrome, don't keep treating as uveitis. And even this masquerade, there could be a sentinel vessel adjacent to the limbus, and as well as a hyperpigmentation. All these subtle markers are helpful in reaching a specific diagnosis. So what to look for atypicality in hypopyon is, you can see a granularity or even vascularity. The surface is not flat enough. All those should help you to do a specific diagnosis, and that a tap could help us in reaching the retinoblastoma. And the treatment is going to be entirely different in these scenarios. And as you know, biofilms we see post-op, it can be due to Propionibacterium acne, they will have a dendritic capes, and this dendritic capes can happen in other conditions apart from P. acnes like sarcoid, even toxo and fungal as well. Though shifting hypopyon is very, very important sign for Behçet's, we all know that, and not to miss this head tilt test following intravitreal triamcinolone, which could mimic shifting hypopyon as well. This triamcinolone keeps shifting, whereas your hypopyon following fibrinous uveitis may not. And this non-shifting hypopyon could be a marker of infective etiology. So the color of hypopyon is also important. As you can see, the pink colored hypopyon can happen in Serratia, Klebsiella, and Mycobacterium can cause brown colored hypopyon, and there are different colors. You can look for that. So in a nutshell, what are we going to do when the patient walks in? The baseline test, I'll finish in 30 seconds, sir. The baseline test, the complete blood count, Mantoux test for TB, syphilis, chest imaging, and not to miss the TB, Mantoux, quantiferon, gold, and chest imaging. We pre-COVID we were happy with chest X-ray for poor patients. Now for all posterior and pan-uveitis, CT scan is definitely mandatory to rule out the post-COVID manifestations before harping on oral steroids and immunosuppressants. Make sure HRCT is definitely done. Syphilis, we have to do both non-treponemal as well as the treponemal test and other infectious as and when required. So not to miss the drug induced. I will stop my presentation right now. Thank you for your patient listening.
Thank you, Bala. That was a fantastic talk. Very interesting and very illustrative. Thank you so much.